Shoulder instability covers a spectrum from microinstability and subluxation to a complete dislocation and can be due to either a traumatic cause, where an injury has occurred to the ligamentous structures, or an atraumatic cause due to the patient's generalised ligamentous laxity. It's important to differentiate between these causes as it will have a significant bearing on treatment. So I start with Sam. There's something called the Baton score, which is a score out of 9, and you get 1 point for each of these. So if you're able to bring your thumb back parallel to your forearm, you get a point for that. You need to check both sides. Sam so far has got 0. If you can pull your finger back so it's at less than 90 degrees to your metacarpal, you get a point for that. Once again, he's already got 0 for that. If you get the patient to put both of their arms out as far as you can, so I can get you straighten your arms out as far as you can. If they get hyperextension of their elbow, they get a point. Sam hasn't got any points of those. Genu recurvatum, so if I can get you to put your legs back as far as you can to see whether you can over hyperextend your knee, which you can't. And the last thing is to see whether he can bend forward and put both of the palms of his hands on the floor with your legs straight.
Wow.
Have a go. 0. So Sam is not at all a flexible person, so he's got a Baton score of 0. So if he has any instability, it's going to be mainly traumatic. The other thing to look for generalised joint laxity is if a patient has got a sulcus sign. So if you pull directly down on the arm, if someone does have a sulcus sign, you tend to get a little dip. This is really inferior instability. So if someone has got generalised joint laxity, that would be an indication of this. Once again, Sam's shoulder is normal. Anterior instability of the shoulder accounts for over 95% of cases. The position of instability is with the arm abducted and externally rotated, where patients will experience a varying amount of apprehension. This forms the base of most tests. Posterior instability is far less common, and patients usually don't have any apprehension. As a result, different types of tests are required. So with Samuel, I'll get Sam to bring his arm up into the position of instability, which is abduction and external rotation, and he may say that this feels like his shoulder's going to come out. If you're able to get them up into that position, that's not particularly uncomfortable. The next thing to do is to put a little bit of external rotation in to see whether that causes any discomfort. Another thing you can then do is to actually put your thumb on their humeral head and actually try and push their shoulder forward as if you're trying to actually dislocate their shoulder. Obviously you want to try and avoid doing that, but they may have some discomfort in doing that. What we want to do is want to have the patient lying supine, and we want to stabilise their scapula. So I'm just going to get Sam just to move yourself just a little bit over the bed, so your shoulder's just on the edge of the bed, but the scapula is nicely fixed in position. What I'm going to do is I'm going to bring his arm back up into abduction and external rotation as we did with the apprehension test. I'm actually going to push my hand on the front of his shoulder, reproducing the stabilising structures. That's going to allow me to just crank his arm a little bit further into external rotation. Now the surprise bit is if you bring the arm away, because you've brought the patient's arm round into a little bit more external rotation, they'll tell you that's pretty uncomfortable, and sometimes they jump off the bed, so you need to be a little bit careful doing that. This is a far more sensitive test than the apprehension test. If someone has a positive apprehension test, they have a positive relocation test. We'll get the patient's arm, so I'm going to bring your arm across your body there, Sam, and I'm actually going to internally rotate it. Then I'm going to put a traction force pushing backwards, so I'm trying to sublux his shoulder posteriorly. So if Sam were to have some posterior instability, his shoulder would actually be subluxed. If I now bring his arm backwards, what I should be able to feel would be his shoulder reducing. This is sometimes called the jerks test, and this movement, bringing the arm forward, is sometimes called the Yankees test. The most important thing is to feel with your thumb posteriorly on the humeral head. So if he has got instability, the head will have come out. Actually, the real diagnosis is made as you bring the arm forward and you can feel the shoulder gliding forward. The patients tend to have no discomfort when you're doing this. Damage to the glenoid labrum can cause microinstability and subluxation, particularly in overhead athletes. This is often difficult to accurately assess clinically, and no one test on its own is diagnostic. For this one, we get the patient to bring their arm up into elevation at 90 degrees and then just across their body. I'll then get the patient to put their thumbs so they're pointing down as far as they can. When you do this, this brings the long head of biceps up superiorly. I'll then push down against the patient, and I get you to push up against me, Sam. And if they have got any labelled pathology, they may experience some pain and discomfort. This test is very similar to a test for the AC joints, the scarf test. So if someone has got some additional pathology of the AC joint, they may experience pain just having their arm in this position. To check that that isn't the case, if I can then get Sam to put your palm so it's facing up, that will actually bring the long head of biceps below the midline. If I get you to push up again, if they've got some labral pathology, that test would be normal. So if they've got pain with the thumb pointing down but not pointing up, that's a positive O'Brien's test, and that's an indication of the possibility of some biceps labral pathology. Essentially, you just want the patient to have their arm loose, and then you want to try and push in and see by grinding the shoulder whether you can actually catch a labral tear, which is similar to a meniscal tear. So once again, the patient will tell you if there's some discomfort, and you can sometimes feel a bit of grinding.